Today, first we'll talk about the erythrocyte disorders, abnormality in red blood cells. One very commonly heard disease or clinical condition related to the red blood cells is anemia. So we'll talk about anemia. First we'll see the definition of anemia, then we'll see the types of anemia and the causes. Then we'll talk about another thing that is called polycythemia. It's not listed here, polycythemia. Then we'll go to the white blood cells. We'll talk about the properties of white blood cells, different types of white blood cells. In last class I mentioned there are 5 different types of white blood cells present in the or found in the blood. We'll see what are those different types of white blood cells, how they look like under the microscope, and their important functions. Then we will talk about thrombocytes or platelets. Platelets are also called thrombocytes. We will talk about the properties, functions, and production of platelets. Then we will talk about a very important process that is called coagulation, blood clot formation, how coagulation takes place. We'll see that. Then we'll talk about the blood types or blood groups. So those are the things we'll cover today. First, what is anemia? Anemia is a clinical condition in which the blood has abnormally low oxygen carrying capacity. Now, you know that oxygen is essential for metabolism, right? So if blood cannot supply enough oxygen to the tissue, then tissue will have less metabolism. Make sense? Less oxygen, less metabolism, and will cause some symptoms of anemia. So what are the symptoms of anemia? The person or the patient will feel extreme tiredness, fatigue, paleness. Since when oxygen binds with hemoglobin, we know that hemoglobin gives bright red color, right? But if less oxygen binds with hemoglobin, then the color will be pale, not bright red. So the skin of the patient, or particularly the mucous membrane, will look pale. Shortness of breath, since the person's body is getting less oxygen, the person will be hungry for air. Shortness of breath and chills. So those are the symptoms of anemia. Now, types of anemia. There are different types of anemia. One type is called insufficient erythrocytes induced anemia. Meaning is very simple. Insufficient erythrocytes induced anemia. That means lack of red blood cells. Now, what can cause decreased number of red blood cells in your blood. One is hemorrhage, bleeding. If bleeding occurs, we will lose blood. Blood cells get out. So the number of red blood cell count will go down. That anemia is called hemorrhagic anemia due to blood loss. Blood loss could be acute or chronic. Acute is sudden loss of lot of blood. Okay. Example, major surgery, road accident, right? You can lose a lot of blood suddenly. That is acute loss, acute hemorrhage. Chronic loss includes ulcer. For example, you got an ulcer in your stomach or somewhere, and from that ulcer slowly blood is getting out from the body for a long time, like months or years. So although small amount, but you will lose a lot of blood eventually, and that will decrease the count of red blood cell. Another example, worm in your intestine. You know, sometimes hookworm or tapeworm, those can grow in your intestine and they love to suck the blood, right? Worms, if they reside for a long time, slowly they will suck your blood, and that can cause chronic blood loss, hemorrhagic anemia. Hemolytic anemia. We know that the lifespan of red blood cells is 90 to 120 days, but if for any reason someone's red blood cells are destroyed before that, excessive destruction of red blood cells, premature destruction of red blood cells occur, that is called hemolytic anemia. Hemolysis. Lysis means breakdown of red blood cell. Excessive breakdown. Aplastic anemia. If the site of red blood cell production, which is the red bone marrow, is destroyed or is inhibited or depressed, the production will be less. So destruction or depression of red bone marrow will cause aplastic anemia. So the production of red blood cell is less. What can cause the destruction of red bone marrow or inhibition or depression? Excessive radiation. If someone goes through too much X-ray or radiation, bone marrow could be depressed. High dose of antibiotic like penicillin, that can also cause. So some drugs can also do that. So those are insufficient erythrocyte induced anemia. Another type of anemia is low hemoglobin content anemia. In this case, the amount of hemoglobin is low. So two different things. You see here, this is person A, this is person B. The one I have mentioned before is insufficient red blood cell induced anemia. So this person has, this is normal person, has 10 red blood cell, for example, and this person has less. So oxygen carrying capacity of this person is low, makes sense? Decreased number of red blood cells. But you see here, both have same number of red blood cells, A and B, but this person has normal amount of hemoglobin inside the red blood cell, but this person has less hemoglobin inside the red blood cell. So oxygen carrying capacity of this person will be low because hemoglobin carries oxygen, we know that, right? So total amount of hemoglobin or concentration of hemoglobin is less in this person, right? So although the number of red blood cell count is normal. Okay. Now, what can cause decreased synthesis of hemoglobin? One is iron deficiency. You know that iron is an important component of hemoglobin. So iron deficiency can cause low hemoglobin content anemia. Another is vitamin B12. Vitamin B12 helps in the synthesis of hemoglobin, acts as a catalyst, and uh, that anemia is called pernicious anemia. Vitamin B12 deficiency anemia is called pernicious anemia. Abnormal hemoglobin content anemia. Abnormal hemoglobin content anemia is another type of anemia. Now, you see, both person A and B could have same amount of hemoglobin, but the quality of hemoglobin is another factor. This person has enough hemoglobin, but the quality of hemoglobin is not good. Abnormal hemoglobin, not normal. So this hemoglobin is not able to carry enough oxygen. Make sense? If the hemoglobin is abnormal. Two commonly heard abnormal hemoglobin content anemia are thalassemia and sickle cell anemia. In both cases, the globin chain is faulty. Faulty globin chain. You know, hemoglobin has heme and globin. You already know that. Globin is amino acid chain. You already know that. 2 alpha 2 beta chain. So this is globin chain, for example, and these are amino acids. So if the sequence of amino acid is changed, that can cause abnormal hemoglobin. Okay, globin chain. Sickle cell anemia occurs due to the abnormal chain in the globin. In one location, you see the globin chain has amino acids, valine, histidine, leucine, threonine. So all those are amino acids. Line up, chain. If at one place the glutamate is replaced by valine, valine is another amino acid, that can cause the change of the hemoglobin. The hemoglobin will be hard and the shape will change like sickle. Have you heard the word sickle? Anybody? Sickle? Carved knife, right? Knife-like thing that farmers use. So, if the glutamate is replaced by valine in globin chain, that will make that hemoglobin abnormal. What will happen? The hemoglobin will get hard like crystal and both ends will be pointed and the hemoglobin will be carved like a sickle. And that hemoglobin cannot carry oxygen. And this sickle cell anemia occurs more in African blacks. This is a genetic disorder. Genetically, this globin chain could be faulty. Okay. Another condition related to the abnormal number of red blood cells is polycythemia. Polycythemia is the condition where the blood has excess count of red blood cells, increased number of red blood cells in the blood is called polycythemia. Now, polycythemia could be two types, polycythemia vera and secondary polycythemia. Those are two types of polycythemia. Okay. Polycythemia vera is a clinical condition and secondary polycythemia is a physiological condition, not a clinical condition. Polycythemia vera occurs due to bone marrow cancer. The bone marrow starts to produce the red blood cells. Uncontrolled production of red blood cells occur in this condition because of bone marrow cancer. High number and uncontrolled abnormal multiplication. So the number of red blood cell will be high, and this is a clinical condition. Secondary polycythemia is also called physiological polycythemia. Why? Because this is a normal response of your body. Sometimes what happens, if you go on the top of the mountain where you have lack of oxygen, right? Less oxygen there, your body will respond to that environment by producing more red blood cell because oxygen is less there. If the body produces more red blood cells, they should be able to carry more oxygen. When it will come back to normal sea level, the number will go down again. So that doesn't occur due to any abnormal clinical condition or disease. That is a normal response of your body. Make sense? Normal response. If you go on the top of the mountain where lack of oxygen, your red blood cell count will go up. When it will come back, it will go down. So those are two types of polycythemia. Another condition that is induced polycythemia, you can induce just by injecting red blood cells into your blood. That is called doping. Sometimes athletes do that. That is not allowed. That's not a legal way to increase the red blood cell count. But you know what athletes can do? They can take their red blood cell out and put somewhere, and before the performance or event, they can inject it into their body. So the number of red blood cell count will go up, right, for a while. And the performance will be better because oxygen carrying capacity will increase. Okay? But that's not a good practice. White blood cells or leukocytes. The white blood cells have some interesting properties. Those properties are only seen in white blood cells. What are those properties? Margination, diapedesis, amoeboid motion, positive chemotaxis, and phagocytosis. So if I ask you in the test, write 5 important properties of white blood cells, you will mention it. Don't write that white blood cells have cell membrane, they have nucleus. Most of the cells have that, right? Those things. So what makes the white blood cells different than other cells? That is the property of that cell. So what is margination? This is the blood vessel. when the blood passes through the blood vessel, white blood cells, these are white blood cells. If there is any infection or inflammation around that blood vessel, these white blood cells can detect that and sense that something is going on around the blood vessel. So in that case, these white blood cells will do what? Will line up. Instead of passing through the blood vessel, they will move to the side and will get attached to the wall and will line up like this. That is called margination. Margination. Then what happens next? In the wall of capillaries and venules, particularly small veins, you have many holes or pores. So the white blood cell will get out through those tiny holes. And the size of the white blood cell is bigger than those holes or pores. So what they will do, they will push a small part of the cell membrane and then push the fluid, and gradually will be able to get out, squeeze through the tiny holes. And that process is called diapedesis. The way white blood cells get out through narrow holes. The next is, after the white blood cell gets out, it will start to move towards the site of inflammation or injury. You have bacteria or virus or dead cells here. So the white blood cells will start to move towards the site of inflammation. How the white blood cells move? They move like anemia, amoeba. You know amoeba? Amoeba produce steps like this. And white blood cells will do that. Cell membrane will be extended and will produce steps like this and will move towards the site of inflammation. And that motion or movement is called amoeboid motion. Movement like amoeba. Movement like amoeba. And what attracts the white blood cells towards the site of inflammation? Why the white blood cell will get out and will move towards the site of inflammation? Because of the chemicals released here at the site of inflammation. Because of the chemicals. That chemicals will attract the white blood cells, will tell the white blood cells, come this way. And that attraction is called positive chemotaxis. Positive chemotaxis. Chemo refers to chemical attraction. And why white blood cells will go to the site of inflammation? To engulf the microorganisms and dead cells. At the site of inflammation, some cells die. So they will engulf the dead cells to clean that area and also destroy the microorganisms by phagocytosis. So phagocytosis is another important property of white blood cells. So these are the properties: margination, diapedesis, amoeboid motion, positive chemotaxis, and phagocytosis. Okay, so those are important properties of white blood cells. There are 5 different types of white blood cells. We group those 5 white blood cells into 2 types, granulocytes and agranulocytes. Granulocytes have granules in the cytoplasm. Agranulocytes don't have granules. That's why absence of granules. A. So granulocytes are neutrophils, eosinophils, and basophils. Those are granulocytes. Agranulocytes are lymphocytes and monocytes. One easy way to remember, granulocytes end with phils. Philia. They attract stain or dye. Okay? Agranulocytes end with cyte. The neutrophils are the most abundant type of white blood cells. About 50 to 70% white blood cells are neutrophils. So if you count 100 white blood cells, you should be able to find 50 to 70 neutrophils. So most common type. Then second most common type is lymphocytes. 25 to 45% of the white blood cells are lymphocytes. That means if you count 100, 25 to 45 should be lymphocytes. Other 3 types of white blood cells are small in number. For example, eosinophils only 2 to 4%, basophil 0.5 to 1. Most rare, least commonly seen, basophils, least commonly seen. 0.5 means if you count 200, you will see 1. Monocytes are 3 to 8%. Okay, so those are 5 different types of white blood cells. Now, how they look like, how you can identify them under the microscope. If you see a neutrophil, neutrophils have multi-lobed nucleus. So in the nucleus, you see multiple lobes. Usually we see 2 to 6 lobes. Okay? Nucleus is multi-lobe. Cytoplasmic granules, since it is a granulocyte, it has granules. The granules take both acidic and basic dyes. So what happens? Both acidic and basic dyes interact and neutralize each other. You know, acid will neutralize the base, base will neutralize the acid. Since the granules take both stains, acidic and basic, they will neutralize each other, and the color of the granules will be pale color. Neutrophils are called polymorphonuclear leukocytes. Poly means multiple, right? Many. Morphology means how it looks like from outside, and nuclear. If you see this neutrophil under the microscope, it will look like that it has multiple nucleus, but actually one nucleus, many lobes. That's why this is called polymorphonuclear leukocyte. Neutrophils are very phagocytic. They engulf the microorganisms strongly. Then, so this is neutrophil. Then another granulocyte is eosinophil. Eosinophil takes acidic stain or dye, FC, which is red color. So, if you see the granules, they take acidic stain or dye. So, the granules are red or orange color. And the nucleus is usually bilobed, 2 lobes in the nucleus. Usually, not always. And the granules take acidic red color. Basophil. Basophil is also bilobed, usually bilobed. But the granules take basic stain, which is purple or bluish. Purple or bluish color. Remember, nucleus always takes bluish color, purple color. So all nucleus will be bluish. So by looking at the granules, you have to decide which one is what. If you see the granules are pale, that is neutrophil. Red or orange, eosinophil. Purple or bluish, basophil, BB. So those are granulocytes. Agranulocytes are lymphocytes and monocytes. Lymphocytes are smaller in size and they have large round nucleus. So nucleus is large and round, that occupies almost the whole cell. So only a thin rim of cytoplasm is around. Thin rim of cytoplasm around the nucleus. So that is the lymphocyte. Very easy to identify. Monocyte is very big, largest among these 5. The size is very big compared to others and have kidney-shaped nucleus. A kidney-shaped nucleus. Now, these two are agranulocytes. That means they don't have any granules in the cytoplasm. Now, just know that eosinophils, the number of eosinophil increases in allergic reactions or in immune response. You know, allergic reaction is an immune response of your body. Allergic reaction is an immune response. So, the number of eosinophil increases in allergic reactions or immune responses. So, by counting that, we can tell someone has allergic reaction. Basophil produces 2 important chemicals. One is called heparin. Heparin is an anticoagulant and histamine. histamine causes allergic reactions. That's why we take antihistamine, the medicine, to inactivate histamine. Okay? Histamine has other actions too, vasodilation, but just know that histamine is responsible for the allergic reaction in the body. So those two important chemicals are produced by basophil. Lymphocytes. There are two types of lymphocytes, T and B. T lymphocytes or T type and B lymphocytes or B type lymphocytes. Okay. You will not be able to identify T or B under the microscope because these are functional types. They function differently, but structurally you won't be able to separate them. You won't be able to separate them by looking at them. The function is different. Monocytes can do phagocytosis or engulf the big microorganisms or even worms in the body. So those are the functions of white blood, how they look like, and their important functions. So monocytes are big and they can engulf large sized microorganisms or even worms. Now some monocytes get out from the blood and enter into the tissue. So through the wall of the blood vessels, some monocytes get out and enter into the tissue and become macrophages. So monocytes are converted to macrophages after they enter into the tissue. So here you see a lymphocyte and a monocyte. So lymphocyte is small, large round nucleus, and monocyte is large and kidney shaped nucleus. Here they have shown different types of blood cells, their count and function. Here this information is important. Platelets or thrombocytes. Thrombocytes or platelets are very tiny, very small. Some physiologists don't agree that platelets are cells. They don't want to include platelets as cells. Why? Because platelets don't have nucleus or any other organelles. No organelles are present in the platelets. Only some granules are present inside the platelets. And that's why the lifespan of platelet is short, 5 to 10 days, and then they are destroyed because they don't have nucleus or other organelles. Only they have some granules in the cytoplasm. Why is that? Because platelets are actually fragment of megakaryocyte. Megakaryocyte. Mega means large, right? So this is a megakaryocyte, a big cell, and what happens? A small part of the cell membrane gets detached from the main body. So you know we have cytoplasm inside the cell, and a small part of cytoplasm and some granules. The cell membrane gets separated with some granules in the cytoplasm. And form platelets. So, inside the platelet, you don't have any organelles. You have small amount of cytoplasm and some granules. Okay, because they are actually the fragment of the membrane of megakaryocyte. Although platelets don't have the organelles, they perform a very important function. What is that? Clot formation. How? If you get a cut, for example, you got a cut here, platelets form plaque. They get attached to each other and form plaque to seal the cut. So, what happens when the platelets come contact to that area where you got the cut, that rough surface of that area will make the surface of the platelet sticky. The surface will get sticky, and one platelet will get attached to another because their surfaces get sticky. Okay. Two chemicals are important to make their surfaces sticky. One is called ADP and another is thromboxane, N-A-X-A-N-E, thromboxane A2. So these two chemicals make the surface of the platelet sticky when they get attached to the rough surface. So they will get attached to each other and form the plaque. The count of platelets in 1 microliter of blood is 150,000 to 400,000. Okay. So that is the count of platelet in 1 microliter of blood. Okay, now we will talk about leukopoiesis. Leuko indicates leukocytes, white blood cells, and poiesis is production. So leukopoiesis is the production of white blood cells. Erythropoiesis is the production of erythrocytes, right? Red blood cells. Now, there are some chemicals or factors that stimulate the production of leukocytes. What are those? Interleukins. There are a number of interleukins, IL-1, 2, like that. So just know that interleukins and other factors are colony stimulating factors, CSFS, colony stimulating factors. So these chemicals stimulate the production of leukocytes, causes leukopoiesis. We know all blood cells come from the stem cell that is called hemocytoblast, not only leukocytes. All blood cells come from hemocytoblast. Here you see how different types of white blood cells come from hemocytoblast. Hemocytoblast is a pluripotent stem cell. plural. It can produce many different types of cells. That's why it is called pluripotent. Can produce red blood cell, can produce 5 different types of white blood cells, can produce platelets, right? So let me write down here so you'll understand better. Hemocytoblast, the pluripotent stem cell, the earliest stage of stem cell, and this can produce any type of blood cells. Hemocytoblast can produce erythroblast, which is also a stem cell. This is a stem cell for what? Anybody? Its name is telling you. Red blood cells, right? Erythroblast. So it will only produce what? Red blood cell. Make sense? So is it pluripotent or unipotent? Unipotent. Only one type of blood cell. It will, although it is a stem cell, right? Okay. So this one will go through different stages of maturation that we have taught in last class, and finally we will produce erythrocyte, red blood cell. Hemocytoblast can also produce myeloid and lymphoid stem cells. Stem cells. Myeloid stem cells produce 4 different types of white blood cells: neutrophil, basophil, eosinophil, and monocyte. So myeloid stem cell produces 4 different types of white blood cells. So myeloid stem cell is not unipotent, right? It is producing different types of white blood cells. And this one is called multipotent. This is pluripotent. It is producing all types of white blood cells. This one is unipotent because only producing red blood cells. This one is called multipotent. It can produce not all but more than one. Okay, multipotent stem cell. Anyway, so this one will produce neutrophil, basophil, eosinophil, monocyte. Lymphoid stem cell produces only one type of white blood cell, lymphocyte. Okay, lymphocyte. And then megakaryocyte produces megakaryocyte that I have shown you a few minutes ago. Megakaryocyte, and the fragment of the membrane, cell membrane, produces platelets. Okay, so that's how from hemocytoblast you get different types of blood cells. Okay. Leukocyte disorder. Leukocytosis. If the number of white blood cell increases, increased number of white blood cell is called leukocytosis. And this increase is not a huge increase of number. Even slight increase of white blood cell number is termed as leukocytosis. And it happens if someone gets infection Any kind of infection can increase the number of white blood cells. Any kind of infection, right? So sometimes doctors ask to count the white blood cells, and if they find that the number of white blood cells is increased a little bit, then they suspect that the person might have some infection somewhere. If they can't see, could be internal infection. So this is a good way to know that someone's body might have infection somewhere, although if you don't see. Leukopenia. The number of white blood cell is lower than normal. Penia means decreased count, decreased number. That is called leukopenia. The normal count of white blood cell is between 4,000 to 11,000 per microliter or cubic millimeter of blood. Okay, so this is the normal count of white blood cells. If the number is, for example, 15,000, then we will say leukocytosis. If the number is 2,000, we will say leukopenia. Now, another clinical condition that is called leukemia, which is commonly known as blood cancer. In this case, the production of white blood cell is extremely high, very uncontrolled multiplication and production of cells, white blood cells occur. So if you count, it's extremely high. And leukemia could be myelocytic and lymphocytic. So two types of leukemia. You remember I showed you that myeloid stem cell produces 4 different types of white blood cells, myeloid. So if abnormal multiplication occurs from this stem cell, myeloid stem cell, in that case this white blood cell number will go up, and that is called myelocytic leukemia. If only the lymphoid stem cell starts to multiply abnormally, the number of lymphocyte will be extremely high. That is leukocytic leukemia. Okay. The problem of leukemia are, number one problem is extremely high number of white blood cells increases pressure inside the blood vessel. Because if the number of white blood cell is extremely high, what happens? Two things happen. One is the thickness of blood will increase, right? Viscosity is the thickness. So the thickness of blood will increase, and also the volume of blood will increase. So both together will increase pressure on the wall of the blood vessel. Is it clear? Both together will increase the pressure on the blood vessel. Now, that pressure will not cause any rupture of big blood vessels, but capillaries. Capillary wall is extremely thin. Okay, so many capillaries will be ruptured due to pressure, and that will cause overwhelming bleeding throughout the body. Okay, bleeding due to the rupture of the capillaries, small blood vessels. Another is, although the patient's blood has many white blood cells, those white blood cells are non-functional white blood cells, abnormal white blood cells. Make sense? Those are not normal. So those abnormal white blood cells are non-functional. So the person will get multiple infection because white blood cells are responsible for immunity, we know that, right? So if you have many white blood cells, much higher than normal, but those are useless, the person will get infection easily. So those are two main problems: hemorrhage, internal hemorrhage, and multiple infections. Platelets. I have already shown you platelets come from the fragment of megakaryocyte. The formation or production of platelet is controlled by a chemical that is called thrombopoietin. Erythropoietin regulates erythropoiesis, right? Poiesis is production, poietin does production. Thrombopoietin. As I have mentioned and shown you on the board that platelets don't have nucleus or organelles, they have only few granules, right, in the cytoplasm. So what are those granules? Those granules contain some chemicals. Which chemicals? Serotonin, calcium, ADP, platelet derived growth factor, PDGF. So those are the chemicals present in those granules in the platelet. Now, just know I have already mentioned that platelets form plug. The surface gets sticky, so the platelets get attached to each other when they come contact to the rough surface. So platelets have the tendency to form plug when they come contact to rough surface anywhere. Okay, and here you see hemocytoblast, pro-megakaryocyte, megakaryoblast, pro-megakaryocyte, megakaryocyte, then platelets. Those are the steps. So hemocytoblast is the stem cell for all blood cells. We know that. Coagulation is the process by which the liquid blood is converted to a semi-solid clot. And the process hemostasis. Hemostasis is the stoppage of bleeding. When you get a cut, you know that in few minutes bleeding stops usually. And that stoppage of bleeding or arrest of bleeding or haltage of bleeding is called hemostasis. Now, hemostasis occurs in 3 steps. First, vascular spasm, then platelet plug formation, and then blood coagulation. So those are 3 steps of hemostasis. Now, what happens when you get a cut? This is the blood vessel, for example capillary or small blood vessel. This is the lumen. You got a cut here. So first what happens? The size of this lumen gets small. Constriction of lumen occurs. That is called vasoconstriction or vascular spasm. Now, when the size of this lumen gets smaller by vascular spasm, less blood gets out. So that is the first step. Blood loss is how the blood loss is prevented. Okay, so the lumen will get narrow. Why that happens? Vascular spasm. In the wall of the blood vessel, you have a smooth muscle fibers, and contraction of smooth muscle causes constriction of the lumen. So contraction of the smooth muscle in the wall of the blood vessel causes constriction of the lumen. Make sense? And that is vascular spasm. Why the smooth muscle contraction occurs? That is stimulated by pain reflex. When you get a cut, you get pain there, and that pain reflex stimulates the smooth muscle, contracts the smooth muscle. Next, what happens? Since the area is rough here, I told you before, platelets love to get attached to the rough surface. So, platelets will start to get attached and form a plug. That is the step 2 to seal the opening. And then last step is coagulation. Coagulation is the conversion of fibrinogen. Do you remember albumin, globulin, fibrinogen, 3 types of plasma proteins we have talked about? Do you remember? Okay, so fibrinogens form mesh, right? So fibrinogen, that plasma protein, will be converted to fibrin fibers. Fibrin is fiber. So many fibrin fibers will get attached to each other to form the mesh. I showed you this in last class. So fibrin mesh will form, and this is coagulation. Production of fibrin from fibrinogen. And then what will happen? This mesh will cover the plug and make it strong. Okay? So that is the last step of hemostasis, or stoppage of bleeding. So mesh stabilizes the plug. You remember I mentioned ADP and thromboxane A2. Those are 2 chemicals. They make the surface sticky, platelet surface sticky. Okay, now this is coagulation. Fibrinogen is converted to fibrin. But to come to this reaction, the blood has to go through 2 pathways. One is called extrinsic pathway of coagulation, extrinsic pathway. Another is called intrinsic pathway. Okay. So coagulation occurs in 2 pathways, extrinsic and intrinsic. Now, in your blood, there are total 13 coagulation factors present in the blood. In your blood, you have 13 coagulation factors present. And they are named like this, Roman numerals 1 to 30. Okay? 1, 2, 3, 4, 5, 6 to 30. And extrinsic pathways use some of those factors, and intrinsic pathway uses some of those factors. But just know that finally both extrinsic and intrinsic pathways, although they go through different reactions, they produce a common product that is called prothrombin activator. So they go through different reactions, but finally they produce a common product that is called the prothrombin activator. So now you tell me, what should be the function of this? Its name is telling you. Activates prothrombin. Make sense? That's why it is called prothrombin activator. So what the prothrombin activator does, works on prothrombin and activates it and produce thrombin. So this is inactive, this is active. Who converts the inactive prothrombin to active thrombin? Prothrombin activator. Is it clear? Okay. Then thrombin does what? Thrombin converts the fibrinogen to fibrin. Okay. Thrombin is active and it converts the plasma protein fibrinogens to fibrin threads, and then fibrin threads will form the mesh. Okay, so that is the process of coagulation. Now, lack of any of those 13 factors can stop or slow down the process. Lack of any of these 13 factors present in your blood, should be present in your blood, can slow down the coagulation process. Make sense? Or may even stop the coagulation. So these are very important. Now the last thing about coagulation here, the process of coagulation. When the extrinsic pathway will cause coagulation, when the intrinsic pathway will cause coagulation. When you get an injury from outside, that will activate the extrinsic pathway. Okay, so that happens when you get a cut, right? You get a clot, the extrinsic. Now you also know that sometimes without any cut, clot is formed inside the blood vessels. You know that, right? Inside the artery or vein, blood clot is formed. That is dangerous, right? But without any cut from outside. So that occurs by intrinsic activation, intrinsic pathway activation. Okay. So that's why we say for extrinsic pathway we need tissue factors, injury to the tissue. Okay, due to the tissue outside of the blood vessel or even the wall of the blood vessel, tissue should be injured. Tissue factors activate that. Here is the fibrin mesh. clot retraction. After the clot is formed, within 30 to 60 minutes after the clot formation, clot retracts, squeezes, gets smaller. Why that happens? Inside the platelets, you have actin myosin filaments. You must remember from NP1, right? Actin myosin, contractile proteins, they contract the platelets inside the clot. So the clot gets smaller. When the clot gets smaller, the fluid from the clot is released to the outside of the clot. Because clot is semi-solid, so it has some fluid inside, so fluid gets out. And that fluid is called serum. So serum is the fluid that comes out from the clot when retraction occurs. Now, this serum is different than plasma. How? Serum has no clotting factors. Blood clotting factors are absent because we know that it comes out from the clot. So the blood clotting factors have been already used up to form the clot. In plasma, you have all clotting factors. So basically, serum is plasma minus clot factors. Okay. Because it is the fluid after the clot is formed, has been formed. Disorders of hemostasis. Two types of disorders of hemostasis. One is thromboembolic disorder, another is bleeding disorders. Thromboembolic, that means thrombus and embolus are formed in thromboembolic disorder. The difference between a thrombus and embolus is thrombus is fixed. Like this is the blood vessel, you've got a clot which is attached to the wall of the blood vessel. So this is thrombus. Embolus, for example, due to the flow of blood, this clot got detached from there, and now this clot will start to circulate in the blood, right? So that is the embolus. So embolus is circulating clot, and thrombus is attached to the wall. So anything that circulates in the blood can block the blood vessel anywhere. It can go anywhere and can block, and that is dangerous. So embolus is more dangerous, right? Because sometimes we see the clot comes from the lung or big veins of the leg. If they stay there, that is not that harmful. Then if they come out and block your brain artery or artery of the heart, right? So that circulating embolus could be dangerous. Bleeding disorder, I have already mentioned. If you have lack of any of those 13 coagulation factors, what will happen? What did I say? Bleeding will be prolonged, right? The clot will be delayed. So if that person gets cut for a long time, bleeding will occur. It will not stop. So that can happen due to lack of clot factors. Quickly, I will go over this blood typing. blood type depends on the presence or absence of antigen on the surface of the red blood cell. Very simple. Blood type depends on the presence or absence of antigen on the surface of the red blood cell. That determines your blood type. Okay. So, if someone has antigen A on the surface, the blood type is A. Very simple, right? If A type antigen is present, blood type is A. If someone has both A and B type antigen, then what will be the blood type? AB. There is another antigen which determines the blood type, that is called D. D determines if the blood is positive or negative. If someone has D, that means positive. If no D, that means what? Negative. Is it clear? So, now, what is the blood? What is this blood type? AB positive. Make sense? Now what? AB negative, because no D, right? D determines positive or negative. Now, if you don't have any of those, then what? O. So if you have A, your type is A. Is it clear? B, your type is B. AB both, your type is AB. If none of those, AB. Make sense? If D is present, that is positive. If D is absent, negative. Is it clear? Okay. So that's how the blood type is determined. Now, this is the red blood cell. So blood type is ABO system, that has type A, type B, type AB, type O, and RH system, that is positive and negative. Okay. Now, another thing you need to know is, this is A type, so A antigen is present on the surface. Okay. If this person's blood, the plasma, you know that you have plasma in the blood, this is a rule. Corresponding antibody must be absent in the plasma. So remember, plasma contains antibody. Plasma contains antibody. And on the surface, you have antigen. Antigen on the surface and antibody in the plasma. Okay. So, the rule is what? If an antigen is present on the surface of the red blood cell, corresponding antibody must be what? Absent in the plasma. That is the rule. That is the rule. So, now let's say this blood type is A. So, this is A type blood. So, what type of antigen should be on the surface? You already know. A, right? That's why this is type A. So, this antigen is A antigen. Okay, this one. Is it clear? Because blood type is A. So anti-A must be what? Must not be present in the plasma. Is it clear? Same type of antibody must be absent in the plasma. Is it clear? So who should be present? Other type should be present in the plasma. What's the problem if you have antigen A on the surface and anti-A antibody in the plasma? They will react, will form clamp. You have seen that related to the blood type. But antigen A, antibody A, they will form clamp or clotting. Okay, will destroy the red blood cell. Yes. Now you will tell me. Okay. So now think this blood is AB. So you have what antigen? Antigen A, antigen B, right? So now will be in the plasma. Is it clear? No anti-A, anti-B antibody will be present in the blood. Now tell me O. O doesn't have any antigen, right? So both anti-A and anti-B will be in the plasma. Make sense? So same type will be absent. Okay. Now you know that mismatched blood transfusion causes problem, right? Transfusion reaction occurs. That could be severe. Why that happens? You will understand now. This is a donor, and for example, this is type A blood. So on the red blood cell surface, you have A antigen. Is it clear? And in the plasma, this person has what? Antibody B. Is it clear? Okay, so this is the donor. And let's say this is a recipient. This blood type is B. So B antigen. And in the plasma you have what? Anti-A. Is it clear? Okay. Now this is recipient. This is donor. When you will give this blood A to recipient B, blood type B, what will happen? This anti-A will destroy these red blood cells because same type of antigen here, right? Quickly destroy these red blood cells. But you now think this way, this blood is going there, so how about this antibody B here? But actually it will not. Okay? The reason is the volume of plasma that is getting in the recipient's body is much lower than the total blood, and this plasma will get diluted in total blood. Make sense? And antibody will get diluted, will get weak. So will not destroy the red blood cells of the recipient, but can cause some immune response. Okay? So always when you will do the blood transfusion, now you know what you have to consider: red blood cell of the donor, make sense, and the plasma antibody of the recipient. Those two things you will consider: the red blood cell that is getting in and the plasma of the recipient. Those two things. Okay. So now let's see a little bit different way. Blood type O. So no antigen on the red blood cell surface, right? No A, no B. And in the plasma, you have what? A, antibody A, antibody B, both. And if you give O to, for example, to a person who has AB, he has both A and B. Make sense? And in the plasma, he has no antibody. Is it clear? As he has both, so in the plasma, he doesn't have it. Okay. Now we consider what? The red blood cell of the donor, right? So this is donor, this is recipient. We consider the red blood cell of the donor and the plasma of the recipient. There is no antigen on the surface, right? So when it will get in, no reaction will occur. And no antibody in this case, so no reaction at all. Definitely not, right? Now, let's see, this is A. So, A antigen here, right? Which antibody is here? B. Very good. So, now if you give O to A blood, still no reaction will occur because nothing is on the surface of O, right? So O can be given to anybody. That's why O is called the universal donor. Okay, O can give blood to anybody. Now AB can receive any type of blood for the universal recipient. Why? Because you have A and B antigen, but no antibody. So whatever blood gets in, there is no antibody, right? So will not destroy the red blood cell. So AB is the universal recipient, not donor. O is universal donor. Okay. Antigens are also called agglutinogens, and antibodies are also called agglutinin. Agglutinins. Okay, so we use this term too. So those are the things you need to know. You will now understand. The last thing, erythroblastosis fetalis. This is a serious clinical condition in fetus. If the mother is Rh negative, that means no D antigen is present, and child or fetus is Rh positive, that means the child has D antigen on the surface. So what happens when the blood components from the fetus, because fetus is inside mother's uterus, right? So the D antigens enter into the mother's body, and that D antigen will stimulate the mother's body to produce antibody. Remember, any antigen when enters into the body will react, right? When an antigen enters into your body will react by producing what? Antibody. You know that, right? Antigen will cause the production of antibody. So in mother's blood, antibody will start to build up. But this production of antibody in mother's blood is slow production of antibody will occur. And first child will born without any problem because mother's body still didn't produce enough antibody. It's producing slowly, okay? And after the childbirth, first childbirth, mother's body will continue to produce antibody in response to that antigen. Make sense? Will continue produce. And when second child, again, if the mother conceives and second child is again Rh positive, that means has D antigen here, right, on the red blood cell. What will happen? The antibody from mother's blood will enter into fetus, and that antibody, D antibody, will destroy his red blood cells. Make sense? Because it has D antigen on the surface. So fetus red blood cells will be destroyed by mother's antibody. Make sense? And that will cause what? Loss of red blood cells in fetus blood, right? And when the red blood cells are destroyed, you know that bilirubin is formed, right? Yellow pigment. More destruction of red blood cell, more bilirubin. So jaundice. Commonly we see erythroblastosis fetalis. Fetus gets severe jaundice. Makes sense? Excessive destruction of red blood cells. Now, when the red blood cells will be destroyed in fetus blood, fetus body will produce new red blood cells. That is normal response, right? Fetus will produce more and more red blood cells to replace those dead cells. And what happens, interestingly, when the fetus bone marrow or liver will try to produce more red blood cells very fast, many immature red blood cells will come out, enter into circulation, into blood, because we'll try to replace, right? Immature red blood cells are called what? Erythrocyte or blast? Blast. So in fetus blood, you'll see many erythroblasts, not erythrocytes. Erythroblasts have nucleus, no hemoglobin. You know that, right? Cannot carry oxygen. So those are useless. So that's why the fetus, that disease is called erythroblastosis fetalis. Erythroblasts in fetus blood. Is it clear? Erythroblasts, immature red blood cells in fetus blood. They cannot carry oxygen because they don't have hemoglobin. Make sense? Okay. So if the mother is Rh negative, fetus is Rh positive, first child will born safe, second child chance is good chance, third is more getting sick, getting erythroblastosis fetalis. Okay, so that's all.